invitation to observe a moment of silence for the original Blackness, Cecilia Makiwane. Many of you who know the history of nursing in this country will know the meaning of her name. So I'm inviting us now to observe this moment of silence for a minute. When I feel that we can stop, I will indicate. Just before you start this observation, I want to also ask that you keep not only Cecilia Makiwane in his name and memory in your heart, but you also keep the names and faces of the many, many, many nurses we have lost, both to the devastations of the exploitative systems that we are going to talk about here in these 2 hours, and more recently, COVID-19. So please come, colleagues, join me. Thank you. We can now breathe and begin our deliberations. I hope you can still hear me. Now, what do you get when you have, on the one hand, a system of neoliberal capitalism, big words, yes, we will talk about them. Austerity, patriarchy, and sexism. You get a toxic mix that robs both those meant to hold a system meant to care of their dignity, of their rights, as well as those who the system is meant to serve. This report says things we've known. We all grew up knowing that nurses, community care workers are both the problem and the solution. When the system, we grew up believing that they are in fact the system. And I think to the extent that they constitute the majority of workers in our healthcare labor force, they are the system for many of us. When the system fails us, it is nurses who have failed because they are the embodiment of the system. When the system works, of course, you know, it's the government is good. It's not the nurses. But we know that there is a bigger story for why often nurses can't serve the level of quality that we expect. We know that the conditions under which nurses work are often impossible. And so paying attention to the experience of healthcare workers, nurses, and community health workers is fundamental to our understanding of why the system is broken and why it is that despite what our constitution says, we are not in fact enjoying free, for many of us it's supposed to be free, quality health and dignified healthcare. The report we are going to hear more details about and which you've seen is not saying anything new. We've known these things, and you know, for many of us who are on this call, you know, we've been working in the area of health, you know, coming at it from different perspectives, and trying to argue that the system you know, must be mended because it is broken. But in order to really get to the heart of what it's going to take to mend this broken system, we have to understand what the changes that have to be made are. We have to understand the brokenness at the source. We have a system on the one hand that's anchored on a profit motive, where the private healthcare industry, you know, extracts the most that it can out of what should be a public good, because health is meant to be a public good. On the other hand, we have a government that is simply not investing in a way that is capable of meeting the needs, and on top of that is not making the bold decisions that are meant to create one healthcare system in South Africa. And without, you know, these bold decisions, the people who are holding up the system, as well as those the system is meant to serve, will continue to be robbed of their rights and their dignity. You will hear from the research teams and from, you know, nurses and healthcare workers themselves, you know, in this 2 hours we're going to spend together, just how bad this really is. But you will also hear of the courage and the resilience and the determination to make things better for us as those whom the healthcare workers are meant to serve. So in the spirit of honoring those who have been holding the system, who have been fighting the good fight, and I do apologize to the program, what do you call them? To the program director. You must never put me on a podium because I always break the rules. So having started with a moment of silence, I want us now, before I introduce our program director, Osis Tembele, I want us to sing, because just because we are on lockdown doesn't mean we can't sing. And I want to invite Osis Fikile to lead us in the song Zizo Jikizindo, because she has a better voice than me. Zakalake, and then you can take over, sis. Zizojikizinto tulamdwana dalukalelani Amanda, thank you. So yes, just because we are sad doesn't mean we can't sing, and just because we are locked down doesn't mean we can't sing. And we do believe, as the song says, that things will change because we are all here coming together and continuing the good fight. So I apologize to the program director. I broke the rules because my job was really just to welcome everyone. It's fantastic to see all my comrades. Because in my culture, you must obey the rules of hierarchy and age. I see you, Sis Letitia, there. Hi, Sis Leti. Okay, she's not greeting me back. I want to acknowledge Usis Fikile, our leader in the struggle. I want to acknowledge Usbongile from the Treatment Action Campaign. Hi, my leader in the struggle. I want to acknowledge all of you colleagues and really thank you for coming out despite the challenges that we all know. Ordinarily, we'd all be together singing and dancing and like throwing our fists in the air and breathing energy and inspiration into each other. So we're gonna try and do that through the airwaves. And then of course, I want to acknowledge all of the professionals, the experts who have supported this project from the beginning to the end. Usis Tembele is going to name their names and is going to introduce them throughout. I also want to thank our team, Ubasani and the colleagues at Oxfam South Africa who have worked solidly over the last year on this initiative where, as an organization, we've been trying to say, how do we contribute to exposing the flaws of this system and to stand alongside and behind healthcare workers who have been fighting this fight, but also, in defense of our right to quality healthcare. So thanks, everyone. You are all thoroughly welcomed. Sis Tembele, I'm assuming that everybody knows you. And that I will apologize that I'm not going to read your full CV. People, she's a doctor, she's a very important person. You must respect her. And she's been in this struggle trying to change our system. Basane, if I can just ask that we send to colleagues bio Sis Tembele with apology that I'm not going to read all of your auspiciousness, but your auspiciousness is acknowledged, and thank you for joining and supporting this initiative. It's over to you now. I promise to obey all your rules. Thank you.
Thank you so much for that generous welcome and for really setting the scene for what we're going to be doing here today. Thank you everybody who's joined us on this call, both here on the Zoom call, but also the people that are joining, that are watching the live stream on Facebook, and those who are watching the live stream on YouTube. Thank you very much for being with us today as we launch this very important report at this very difficult time in the life of the country as we tackle and try to deal with this COVID-19 pandemic. We're now sitting on about 144,000 people infected, and with Gauteng and the Eastern Cape emerging as new hotspots for the spread of the COVID-19 virus. And what we've heard from government officials, from various people, is about how important the healthcare system is. And what this report that we're going to be discussing today shows is how much, despite all of government's nice words about the importance of the healthcare system, how neglected and abused an essential part of that system is. And those are the healthcare workers. And we are today going to be releasing and launching a report and a campaign. The report is called "The Right to Dignified Healthcare Work is a right to dignified health care for all. And this will basically be placing a spotlight on the working conditions and the circumstances under which nurses and community healthcare workers are expected to do their work, and what the impact of that is on their healthcare system broadly. As Sisipo has spoken about, what this report really reveals is how toxic the interaction of neoliberal capitalism, of austerity in terms of budgeting from our government, and patriarchy, how those three things mesh together to create a really toxic environment that isn't just bad for the people that are working in the system, but actually leads to substandard and actually harmful and dangerous healthcare outcomes for the country as a whole. The way that we're going to be running the program today is that the aim is to really have a conversation, both between both with the people who have done the research, but also with healthcare workers themselves, to hear stories and experiences of healthcare workers that really flesh out and add life to the findings of the report that will be discussed this morning. The way that we're going to be doing the program is that we are going to, in between now and 11 o'clock, have a presentation of the report by the researchers from Oxfam, as well as the launching of the campaign that is going to be centered around this report going forward. And then we are going to then from 11 o'clock have a discussion around the experiences of healthcare workers and hearing testimonials and stories from different people who are working on the ground. There will be a question and answer session from 10:30 to 10:50 that will particularly be targeted at the media, at any journalists that would like to ask specific questions about the report. And then we will have a discussion, a further Q&A and a discussion section from 11:30 after we've heard from the different healthcare workers to really discuss different views on everything that we've heard and to then plot a way forward. I'd just like to ask to go back to the slide on ways of working. The way that we will be doing things together is that you know, with this Zoom platform, it can get a bit unwieldy. So please may I request that we only have the people who are speaking switch on the video. This is for everyone except for the people who are sitting at the Oxfam offices because everything is happening from there. So, but when we are going to be speaking, when people are going to be asking and answering questions, please can only one person switch on, only the person that is speaking have their video on. Please may I ask that everybody places their calls on mute, their computers on mute so that we can actually hear the person that will be speaking. If you would like to speak or raise any kind of question, please will you put your name in the chat box and Akona will prompt me to call out to you to ask your question. Otherwise, you can also use the raise hand function that's in the participants box. We have so much to cover today, and so I'm going to be very strict on time to make sure that we are able to cover everything we're dealing with today and to hear from everybody we'd like to hear from. To begin then, I would now like to call up our first two speakers. I would like to call Dr. Basani Baloyi, who is the Inequality Program Head of Oxfam South Africa, and Ms. Ruth Mhlanga, who is the Private Sector Policy Advisor of Oxfam in the UK, to present the findings of the report to us. Basani is a Senior Fellow in Research and Policy at Oxfam South Africa. She has a doctorate from the University of London School of Oriental and African Studies. She has a long career in research and advisory work in the economic sector, and she will be really, and she and Ruth were two of the people who commissioned and have led the research that we'll be hearing about today. So without further ado, Basani and Ruth, please, will you take the floor?
Thank you very much. Could we go to the next slide, please? So just a brief in terms of who we are. This is a campaign in which we are an alliance of various numbers of organizations. The Oxfam South Africa being one of the people as part of this alliance, the Young Nurses Indaba Trade Union, South African Federation of Trade Unions, National Union of Campaign Services and Allied Workers, National Union of Care Workers of South Africa, Treatment Action Campaign, and International Commission of Jurists. Next slide, please. Just a brief in terms of how we went about this process. Oxfam South Africa drafted a concept note along with other Oxfam affiliates, Great Britain, and that was then workshopped with the Young Nurses Indaba Trade Union in a meeting held on the 7th of October, where we ascertained some of the issues concerning working conditions that nurses and community healthcare workers face. From there, a report was generated, a workshop report, and was generated, and the terms of reference were generated, and for which both those documents were then used to commission the study. This is very critical that we reveal this because, just so you understand, that the process has been a partnership. It's not an Oxfam-driven process alone. It's been a partnership with young YNITU, and it's a grounded approach to research, action research, if you may. From there, we commissioned the team at LSE to do the study, as well as others within other Oxfam affiliates, and I must name them: Georgia Murphy, Nicole Olu, Sereng Swenji Cho, and Eleanor Kameli, who led most of the research and got support from others as well. And then we had a first draft that was reviewed by a reference group that was comprised of both YNITU, Oxfam reps, and an external reviewer by the name of Miriam Paula. Comments were had, and then we then sent it off to an external reviews of 7 academics with a variety of specializations. We then had held a series of campaign workshops with the allies that I've just mentioned to you. From there, we sent an opportunity to comment a letter to 3 of the companies, and then integrated those responses into the report, and we now sit where we are launching the report and campaign. Thanks. To the next slide, please. So what we have found a triple threat to dignified healthcare work, and therefore dignified healthcare for all. A gender-blind austerity public healthcare sector, a profit-seeking private healthcare sector, and a healthcare system comprised of public and private employers that use the gaps in labor law and practice to further exploit healthcare workers. This triple threat has combined to worsen the working conditions of healthcare workers, which has compromised the quality of care provided to patients, leaving the system unprepared to respond to crises such as COVID-19 pandemic. To the next slide, please. This divide between public healthcare and private healthcare is visible through the unequal resource distribution. The private healthcare sector has doubled the ventilators, doubled the critical beds capacity, and nearly tripled the existing bed capacity than in the public sector. All the while, the private sector accounts for half of the budget, the healthcare budget, while serving just 16% of the population with medical care. To the next slide, please. The first threat, budget cuts in the public healthcare sector, have been ongoing since 2012. Cost containment has led to a hiring ban on healthcare workers and the de-skilling of the profession, resulting in half the professional nurses being hired between 2012 and 2016 than between 2006 and 2012. This has led to a chronic understaffing within the public healthcare sector, which contradicts the idea that nursing shortages are behind inadequate staffing ratios. Next. The second threat is an extractive, profit-seeking private healthcare sector. From 2016 until 2019, Medicare, Life, and Mediclinic rewarded their shareholders with a combined shareholder bonanza payout of 19 billion rand, while their combined profits were 11 billion rand, meaning they paid out more in shareholder payouts than they made in profits. In 2017, Medicare paid out 1.3 billion rand to shareholders, even when it made losses in that year. What is crucial for us to consider is also the subsidy. The medical tax credits would render private healthcare unaffordable if they were abolished. Yet the 34 billion rand a year spent on medical tax credits could increase the healthcare budget by 60%. These are multinational companies that are all based in South Africa, some of whom are registered in known tax havens. And it's no coincidence that huge gains made by shareholders overlap with deteriorating working conditions for healthcare workers, seeing that the private sector is the dominant client of labor broker workers in the healthcare sector. Next slide. It's important to remember that nursing, community healthcare work, and unpaid care work are culturally and socially viewed as feminine sectors. Therefore, women in general, and Black women in particular, are overrepresented in the sector owing to the system of patriarchy and racism. In South Africa, the number of women in the overall population is 51.2%, yet women make up 90.1% of nurses. Nurses are the backbone of the healthcare sector, as they number 77% of the healthcare workers. They are complemented by 72,000 community healthcare workers. And to be a feminine sector is to be one who is unrecognized, underpaid, invisibilized, and undervalued. The third threat to dignified healthcare work are the gaps in labor law and practice. We look, can we turn to the next slide? Next slide. Next slide. The third threat to dignified healthcare work are the gaps in labor law and practice. We look at working hours, low pay, gender-based violence, specifically transport and safety, labor brokering, gender equity, and universal healthcare. Next slide. In the context of unequal resources between the public and the private healthcare sector, understaffing and a triple burden of disease, a significant barrier to achieving a balanced distribution of work, family, and personal life, and a safe and healthy work environment for healthcare workers in South Africa is weak and poorly controlled through working time regulations. The Basic Conditions of Employment Act, which protects working conditions of workers, core to this is the protection of work time. Three areas of concern for us are the compressed work week, which are 12-hour shifts without overtime pay that cannot go beyond 45-hour work week. The BCEA stipulations around compressed working time week is that nurses tend to formerly work 12-hour shifts starting at either 7 a.m. or 7 in the morning and 7 p.m. These shifts are scheduled to include weekends and add up to approximately 160 hours a month, which adds up to 40 hours a week. Ordinarily, a 3-week shift, which is 33 hours, is followed by a 4-week shift to achieve this average. Community healthcare workers normally work 12-hour shifts between 7 a.m. and 7 p.m., albeit without weekends. The normalization of these compressed working weeks within a predominantly female workforce greatly disregards the double burden of carrying out both the productive and reproductive labor, especially where women are single parents. And many of these facilities that are used is that 5.8% of facilities only have childcare facilities, right? So many healthcare workers are therefore left to find various means of taking care of their children without any support. In terms of Section 6.2 of the BCEA, emergency work is excluded from working time protections due to factors such as emergency patient care and understaffing and the triple burden of disease in South Africa. This is a key loophole that risks being abused and misappropriated within the healthcare system. Indeed, research by the INO concludes that nurses frequently work over this amount of time, with longer than 24 hours not being uncommon. Another area that we look at is the fact that there are blanket exclusions for managers and also for those who earn above a particular threshold of 2,500 Rand. Those care workers are basically excluded from any kind of work time protection. So they are finding themselves having to work longer hours and therefore crippling their ability to take care of patients. So can we go to the next slide? So the impact of this, the nature of the way in which work time is organized within the BCA or in the labor law is that it impacts, it leads to stress, exhaustion, and cancer. Now within, as I said, a framework where there is a critical understaffing of care workers within the health care system, this is one way in which they are further exploited through these loopholes that don't protect their working hours. They work for further, more than they humanly possibly should, leading to stress, burnout, exhaustion, cancer. And the exhaustion also leads to the lower levels of patient care, therefore compromising our healthcare system. And currently, the Department of Health is facing record levels of medical claims as a result of this kind of system. Ruth, you may take over.
So looking at the second policy gap that we found within the research, as already noted, the neoliberal system in which we see this healthcare system operate has resulted in jobs and salaries gradually being stripped of the social protection and with wages stagnating. So importantly, what we'd like to point out here is that particularly community healthcare workers have abysmally low pay, which is set at stipends of 3,500 rands, while the salary increases for nurses of 1% notching up every year has obviously meant that most nurses' salaries have stagnated, coupled with understaffing shortages as well. This means you have a workforce that is slowly being de-skilled under the guise of cost containment and under the guise of cost savings for both the private sector and an austerity-blind government. It's important to note, particularly in the private sector, that there's a lack of transparency about how much nurses and community healthcare workers earn whilst working in these sectors. For example, from what we've been able to find, it will take 65 years for a nurse to earn what the average CEO earns in a year. In just 5 days, an average private healthcare facility CEO will earn more than a nurse earns all year. I think the effects of this problem become somewhat obvious in that we have nurses and community healthcare workers that do not feel that their work is fairly rewarded. It contravenes their human rights and obviously attributes to their physical and mental well-being. Unfortunately, this is also coupled with the social norm whereby society views care work as something that is a calling and therefore undervalues and does not see as this worthy of effective remuneration. We've also seen community healthcare workers and nurses increase the amount of debt that they hold as they are forced to either take on second jobs or take out precarious loans from loan sharks. Unfortunately, as they are on the front line, we also see nurses and community healthcare workers take on the burden of trying to close the gap on medications, transport, and food as they go about their jobs day to day. And as mentioned already, we see many nurses and community healthcare workers having to rely on a second job, moonlighting, or other piecemeal jobs in order to supplement their very low incomes. And as already mentioned, many of these nurses are working very long shifts, as well as community healthcare workers having really long days. And the addition of the second job, as well as the moonlighting or piecemeal jobs, means that we are having overworked, tired community healthcare workers, which ultimately compromises the quality of care available to all South Africans. Unfortunately, gender-based violence is rife in our societies. And what we have found is that in South Africa, the femicide rate is 5 times higher than the global rate. And interpersonal violence death rate is the 4th highest in the world. Unfortunately, nurses are not immune from this and in fact find themselves at the center of violence both at work and in their homes. And while there are policies that should address this, our research has found that there are key gaps in this policy. Unfortunately, there is slow response towards abuse, particularly when it relates to domestic abuse, as the social norms dictate that this should be left to be dealt with partners. Unfortunately, victims and survivors are often forced to go long distances in order to obtain support and to seek legal assistance. As you'll see from the stats on the side, 69.4% of female nurses have reported experiencing some form of violence from an intimate partner. And nurses and community health workers remain at high risk of gender-based violence in their places of work. Community healthcare in particular have reported that they are at risk from those who would be selling drugs or viewing them as carrying drugs, and therefore will be attacked as they go about their day-to-day work within the communities. This puts them at greater risk of violence and puts their well-being as the quality of care at great risk. When we look at transport, we know that the CEA has stated that any work done between the hours of 1800 and 6 a.m. should be deemed as night work. Unfortunately, the availability of transport during these periods is often limited, and most workers and most employers, have decided that availability are at high risk because of identifiable uniforms, and they become targets of criminals who wait for them as they travel to, as mentioned before, both nurses and community healthcare workers, because they often have very long distances to travel and a clear legacy of the apartheid regime, segregated groups and communities. This insecurity obviously has an impact on the quality of care available, as workers who feel under threat, as workers who are insecure, as survivors of gender-based violence are unable to fulfill their duties as required. The 4th policy gap we noted was around labor brokering. As we've already alluded to, we see an increase in precarious work under the guise of increased efficiency and the need to reduce costs. Unfortunately, labor is seen as a cost to be reduced rather than as a right to be enforced. And therefore, with labor brokering, what we see is a breeding ground for precarious work. We've seen the public sector increase the amount of outsourcing that they do, with a rise to about 5% of goods and services. In the private sector, we see approximately 24 to 29% of the headcount being agency workers. This means across the healthcare sector, we've seen an absolute increase in the level of precarious work where jobs strip benefits and salaries have stagnated. So where do we find ourselves with this current policy? Whilst there's been political pressure to make amendments to the BCA as well as the Labour Rights Relations Act, in which both the agency and the client are jointly liable for workers' rights, we know that after 3 months, the agency worker is deemed to be the legal employee of the insource and is subject to equal terms and conditions of their permanent counterparts. And that attempts to circumvent this would mean that this would be a dismissal. Unfortunately, despite that progress, there are still gaps, and would like to draw your attention to 3 of them. The first is that the 3-month grace period that has been allotted means that after 3 months, it is only after 3 months that someone is considered a permanent employee. Unfortunately, rotation means that nurses and community healthcare workers can be continually rotated such that they never gain permanent status, and thereby circumventing their rights. Also, the threshold created by the BCEA of 205,000 rands and 43 means that issues regarding dual employment and unequal terms do not apply to nurses that are just above this income threshold. Again, all of this has the effect in which neither nurses nor community healthcare workers have secure relationships. They are resulting in increased moonlighting, which again affects patient care, and there's also higher rates of absenteeism. It might also be worth noting that just across the border, we have Namibia as a comparison, which has afforded equal treatment from the start of employment, and thus serves as a strong benchmark for advocacy efforts. When we look at the policy gap, we're looking at the future in which we have universal access to healthcare, which is free at the point of access. And therefore, we need a national health insurance that builds universal health cover by progressively taxing the wealthier in order to pool funds and make it available for all. Unfortunately, what we have at the moment is a watered down version that still sees private healthcare playing a significant portion of healthcare. We risk compromising the quality of healthcare as well as healthcare standards because we still have a profit motive driving healthcare provision. As mentioned, the debate as it currently stands is insufficient. What we need is greater cross-subsidization in order to ensure that we have universal healthcare that is not undermined by a private-public mix where health remains as a commodity to be sold on the market. And therefore, our recommendations moving forward. We're calling for a transparent healthcare system that is moving towards universal access, that is resilient, free at the point of access, and takes better care of the workers within the healthcare system in order to provide quality healthcare. We need to recognize and fairly reward the work that our heroes on the front line, the nurses and community healthcare workers included, are undertaking. This means ensuring living wages across the sector. We need to reduce the incidence of precarious work and provide security of contract in order to ensure that those who work on the front line, those who are safeguarding our healthcare, have the right to decent work. We need to recognize and reduce the burden of unpaid care work that women carry. As already mentioned, this is a highly feminized sector in which we find that 77% of over 80% are women. And we know that women have the additional workload of cooking, cleaning, caring for their families, caring for the sick, in addition to their day jobs. And therefore, it is important for employers to recognize the work that is done by women in order to ensure that there are gender-sensitive policies in the workplace. There is also a need to reduce inhumane working hours. Coupled with the incidence of not being paid fairly, we have a detriment of human rights in which workers are forced to work long hours for very little pay. There is need for better governance that allows for a transparent and accountable health system. As alluded quite often to in this research, it was difficult to find information as data is very often unavailable. And it is absolutely crucial that there is accountable, comparable data that allows for scrutiny from both the civil society and from workers themselves. There is need to allow for greater representation and empowerment of healthcare workers that enables them not only to voice their concerns so that they are no longer ignored, but also allows them to move up in decision-making so that they are the ones making decisions over the work that they carry. Importantly, we must end violence and discrimination against women. As we've mentioned, nursing is a gendered sector. And unfortunately, it has been ignored because it is work done by women. And we are saying there must be an end to this discrimination, and there must be an end to the violence against women. There needs to be a commitment to do business responsibly, particularly from the private healthcare providers that have been mentioned, including paying their fair share of taxes and ensuring that we work towards reducing inequality. This means more money must be sent through to workers than is sent to currently shareholders and the wealthiest parts of our populations. Thank you. I'll hand over now to Lebohang.
Thank you very much, Ruth, for that presentation. Thank you, Ruth and Basani, for your presentation that really highlights the major issues and challenges that we have within our healthcare sector. And let's remember that 90% of the people that work as nurses or healthcare work or community health workers are women, and 83% of those are Black women. Black African women. And so what we are seeing is that, and 77% of the public sector's human resources for healthcare are nurses. And so the healthcare sector is based on and relies heavily on the labor of women, of Black women in particular, and yet the labor conditions, the working conditions of those women, as we've heard, are absolutely horrific. When Ruth was speaking about the transport issues, for example, about safe transport, for the workers, for nurses and community health workers that work these incredibly long hours, as we heard, it just made me think about the taxi industry that's decided that they're going to fill taxis to 100% capacity from yesterday. The people that are going to be, amongst the people that are going to be most affected by that are healthcare workers who rely on those taxis to get to work, are working with COVID patients in hospitals, and then face that risk in their daily commute to and from work. So just at that level, I think that example currently just shows just how critical these issues are. I'd now like to hand over to Lebohang Panyeko from SAFTU. She is the national organizer responsible for campaigns and organizing for SAFTU, and will be telling us a bit more about the Care for Carers campaign that is being co-created by YNITU, NUPSAW, NUPSAW, SAFTU, TAC, and Oxfam South Africa. Please, Sis Lebohang.
Thanks, Stebile, for
sorry, Putlo.
I was about to rectify that by asking to say I can see this gender discrepancy. No, it's fine. It's human error. Thank you very much, colleagues and comrades, for giving the try for inviting us. Also to form part of this broader coalition where actually we are fighting against inequality at workplace. We are fighting against the community healthcare workers, the healthcare workers in general, who are daily exploited. So I think comrades can recall this report comes in the eve when the community healthcare workers are on the brutal side of exploitation, and they were locked down in COVID-19 is highly exposed the conditions of these healthcare workers are working under. We should actually thank COVID and lockdown for exposing the system that we are currently actually facing. I'm just going to be brief, colleagues and comrades. I'm not just going to log what the comrades have touched base from Ruth, Asane. They've actually explained the depth of this report. So basically, I'm just going to touch on the slides here that what is it that actually we hope to achieve. We want to see mass free testing and medical attention and PPEs for all healthcare workers. We also want to achieve the recognition of gender nature of healthcare worker and gender sensitivity policies and practices in this campaign. We're also looking for a call actually. We want the healthcare system that recognizes the value and fair rewards the work of healthcare workers. And we also want actually to achieve a quality, universal, people-centered, resilient healthcare system that is responsive to the needs of community, society, and healthcare workers, free at the point of use. And next slide, comrades. So we're seeking to achieve that, colleagues, whereby healthcare is accessible to everyone, not just for the few, not a healthcare system that is centered around profit making, but that is putting people forward before profit. And we're also hoping to in this campaign to join actually to have solidarity. It's not just going to be a campaign around Oxfam, NUPSAW, SAFTU, and YNITU, and TAC, NOCWOSA. We need maximum unity, we need maximum solidarity with other formations that are here. Even the unions, even from COSATU, because I'm talking from the labor perspective, the union from NUPSAW, who are not here because an injury to one and it's an injury to all. So that slogan it's very explicitly clear. So we need maximum solidarity from all the formations who are fighting against the scourge and the attack of community healthcare workers. We also going to have some weekly seminars with healthcare workers where we'll share the findings of this report and also discuss the issues they are facing in order to have maximum support on the ground effort. So it's not just going to be a report that is only surfacing on the air, the eye clouds. It's going to be a grounded campaign. We're also going to invite actually other stakeholders in order to have a buy-in. In building that solidarity call also complete. We are also going to run a long-running campaign which will have a range of petitions, range of mass demonstrations. So we're looking forward to strengthen the solidarity of this report into the practicality of it. And also, there's a joint media statement by all the allies, YNITU, SAFTU, NUPSAW, NOCWOSA, Oxfam, TAC. It is a joint statement explaining actually the brutality of this healthcare system, which is only centered around profit and the exploitation of women out there. So there is a joint statement. I'm hoping it will be issued soon to show the world that we mean business. And secondly and lastly, complacency. In this coalition, we have partnered also through our social media space. You can find us on at Oxfam SA on a Twitter handle, at the Nessus Indaba, SAFTU _media, at NUPSAW, TAC, and NOCWOSA. So this is a benchmark of rolling out solidarity. It's not just going to end here, colleagues and comrades. As I've just said, comrades Tebile, I'm just going to short give a summary of what is it that we want to achieve, and also bringing solidarity with other formations that are if not here. Yes.
Thank you so much, Butlebohang, for that. And I think that this is I think you're completely correct, right? That the COVID-19 crisis and the lockdown, you know, in some ways has been a blessing in disguise in really revealing and blowing open the terrible conditions under which nurses and community healthcare workers have been working for so long, and really putting that out into the fore. And you've got this contrast between what government is saying and how our government has been lauded for its very for its relatively good COVID-19 response compared to counterparts internationally, and yet the system on which government is relying to actually deal with the COVID-19 crisis is deeply flawed and deeply damaged in so many ways. And so, you know, we need to keep highlighting these issues in order to actually have proper transformation of the system. I'm now going to open up to take some questions. We've got about 10 minutes to take questions. Particularly, I'd like to invite our media colleagues, if there's anything in particular you would like to ask about either the report or the campaign, please will you raise those issues now. You can do so, as I said, by either raising your hand in the participants list, or by putting a question in the chat, or indicating in the chat that you would like to ask a question. Is there anybody who would like to speak? Colleagues on Facebook, you can also write a question on Facebook, and it'll be picked up for us to for our participants to answer. While we're waiting for those questions, I'd like to just draw your attention to the screen, to the steps on solidarity for the Care for Carers campaign, hashtag Care for Carers. There are the social media handles of the organizations that are taking part in this campaign, at Oxfam SA, at Nurses Indaba, at SAFTU Media, at NUPSAW HQ, at TAC, and at NOCWOSA as well. So I would really urge you all to follow those organizations on social media. Akona, are there any questions that I'm missing? There's a question here on the chat from Rakhadi, and I will leave this question to direct this question to Basani and to Ruth. How is it that the state is so unwilling effectively to get rid of labor brokering? Perhaps there are vested interests by the very politicians. If any one of you would like to comment on that, please.
Hello. Thank you very much. That's a very crucial question to be asking, like the politics that surround the issues of labor brokering. It has been a long struggle around the issue of labor brokering, and we need to commend the fact that through the hard efforts of certain trade unions, of which NUPSAW being the most, Kawaii, there's been a crucial victory that was won And we cannot in this context where the working class are in constant attack, we must not undermine the various victories that are won and hard fought. So we of course accept and commend the victory around labor brokering, that there have been tightened regulations around labor brokering that have been brought about by an interpretation that ensures that workers earning a particular level and below are then able to, after 3 months of working through a labor broker, are then able to be permanently employed or deemed to be permanently employed by the client. And so, meaning that they will have similar benefits as to those who are permanently, who are not, would have certain benefits that are similar to those who are permanently employed. However, the major loophole is the fact that workers that earn from 205,000 Rand and above do not enjoy that same protection. So, and that is many nurses who have a particular grade 3 and upwards, right, as part of the OSD levels, find themselves in that situation. And it's such an arbitrary minimum threshold, if you think of it, because salaries are adjusted, are inflationary adjusted, at least we hope. We know that there's now been a salary increase, but in an ideal situation, their increments are increasing as per like the salary, like salary adjustments. So therefore, those who find themselves below that threshold are then increased, and below that threshold are then increased as salaries adjust. So it's an arbitrary thing and that's a major loophole in which predominantly nurses and others find themselves in. So whilst there have been tighter regulations, we even know that within that tight regulation, companies are very scrupulous in undermining even the regulations that are currently present that actually protect workers. Where we find that there's rotation, they will employ you for a certain amount of time and then they will fire you just before. So this is a critical problem that is really stripping workers of their labor protections.
Thank you so much for that very comprehensive answer, Basani. What I'm going to do now is I'm going to take 3 questions. There is one raised hand from Tinashe. So Tinashe, I'm going to ask you to ask your question, and then I'm going to read 2 other questions that have been asked.
Thanks, Tembile. Thanks, comrade. My name is Tinashe Njanje. I work with the People's Health Movement. Thank you, Oxfam, and all the partners for this opportunity. My question is around the gap, the huge gap between the CHWs and other health care workers. As you know, CHWs are found right at the bottom, but they are not given that attention. There's no attention given to address that gap. But they are doing equal work, and they are also subscribing equal money to the unions, which I think all the nurses and all other health workers are doing. For instance, they are given 1 T-shirt to spend for the whole week. They don't have shoes, they are not given shoes, but they do work from one community to the other. Right now, the CHWs in Northwest, they are not, in Northern Cape, they are not being paid, but the other health workers have been paid. So I need to know, what are the unions doing to address this gap between CHWs and other health workers? Thank you.
Thanks very much, Tinashe, for that very important question. Then we have a question here from Anna Marriott, who asked the question on Oxfam SA's Facebook. And the question goes, What has been the response of the private healthcare sector actors to your evidence and recommendations? We have long known how resistant these powerful corporations are to progressive change in South Africa. So please will you let us know how have they responded? And then there's a question here from Robinson at Power FM. And Robinson asks, would you attribute the high levels of medical negligence litigation to the, so let me repeat that. Would you attribute the high levels of medical negligence litigation to the way healthcare workers are treated? What are some of the policy gaps that you have identified and how can they be addressed? I will leave those three questions to be answered by either Basani or Ruth or Lebohang.
Okay. Could I ask that for question one, which is really addressed to the trade unions, that we have perhaps Comrade Fikile, who is amongst us, if she could speak to that question, because it's about what are the trade unions doing. And then in terms of question two, I could ask Ruth to speak to that, and I'll speak to question three.
Okay, great. So Comrade Fikile, please will you help us with question one?
Morning, everybody. I don't know if I'm clear.
You are loud and clear.
That is good for me. Morning, everybody. My name is Fikile Dikolomelalengene. I'm the Deputy President of the Young Nurses Indaba Trade Union. I'm just going to apologize for my scotchy voice. I'm currently under quarantine because I'm COVID infected currently. Hence, I couldn't even join the sitting. The question that what has trade unions been doing, I think it's a very good question. And I think it is what made us as young nurses in Indaba, because we are actually just only 2 years in the health space. And we have seen the discriminatory, we have seen the inequality that exists with the community health workers while we work side to side. And I think that question would actually be a good question to ask our former unions of how can they allow such injustice to happen in a sector that is female dominated, because looking at our care workers, majority are female, majority are black, and majority are lacking skills that we feel that the department had a chance to actually push forward. What has been done, we actually don't know. Hence, we're taking up the bait to say, as nurses, we work with these people at the end of the day. They become accountable to us, or they become accountable to the patients. Them not being regulated and formalized. I think, again, that is an issue that we need to look at when we come to the community healthcare workers. They are dealing with people's lives and they're actually not regulated or formalized. Is it why maybe they couldn't find or fit in a space in a healthcare system? Hence, we are actually having these campaigns to say, let us look at this sector, because it is actually not going anywhere under the NHI and the universal health coverage. So we need to get them formalized, we need to get them regulated, and we need to also push them to the levels that they need to be. But it becomes a problem as a union, a small union, when you want to push issues, because I do know NUPSAW push for the resolution that is currently sitting at the bargaining chamber. But I am going to tell you the injustice that is happening currently. Last week, they signed that their contracts must continue. Now, they are not actually even being permanently absorbed. At this time, when they face this front line, we are having a system. We are having people belonging to chambers that do not care about women, that do not care about healthcare workers. How do you say these people must continue on a contract whereby they are not going to have any benefits? And not so exactly now what it surely means is that there is no willpower from the political side. Thank you.
Thank you so much, Sis Fikile, and wishing you a very quick recovery from COVID-19. And I think that something that the YNITU raise is how our nursing workforce is aging. Only, and this is something that is in the report, only 7.6% of the nursing profession is under the age of 30. And so that means that poses a real danger for the sustainability of the nursing profession into the future. Thank you very much for your comments. I'd now like to turn to Ruth.
Thank you. I'm answering the question around what has been the response from the private healthcare providers. And So far, we provided these companies an opportunity to comment on the content of the report, particularly noting where we have raised questions about the amounts of money that are being paid to shareholders in light of decreasing profits. They've responded to that opportunity to comment, and they've said that they have no further comment at this stage. However, that does not mean it is end for us to continue pushing and pressuring these companies, because these payouts to shareholders are a clear choice in which they are prioritizing shareholders over workers. They're prioritizing shareholders over the quality of healthcare. So for us, we're going to continue putting pressure on these companies for better quality healthcare, for reduction in inequality, and of course, the rights of healthcare workers.
Thank you. Thank you so much for that answer, Ruth. I'd just like to remind everyone of these numbers, because when I saw them, I was astonished. The three medical hospital groups, Mediclinic, Netcare, Life, between 2016 and 2019 made 11.7 billion rand in profit, but they paid out 19.7 billion rand to their shareholders. That's ridiculous. And I really think it's something that they need to be challenged on, and certainly something that needs to be kept going with this campaign. Basani, I'd like to turn to you.
Thank you very much, Stay. And just to add on to what Ruth has just mentioned, we mentioned that Netcare in 1 year, in 2017, made 1.3 billion rand, yet made losses of 400 million. Okay? You pay your shareholders 1.3 billion, yet you make losses. How does that work? Okay, how does that work? In what world does that work when we are told that actually the way in which the capitalist system works is that it rewards high performance? Okay, so that's what's happened. When they saw those numbers, they said to us, well, actually, in that year, there were a lot of changes in assets, and you need to understand that the board has a way of actually, the board has a way of paying out to shareholders that we may not understand, we by us. And at that time, they were changing assets and all this stuff. Whether or not that was the case, right? And if we take them at their word that there were these changes of assets and that's why it led to all these losses, the point is that they are making a choice to pay out shareholders. That is a board decision. It's a choice. It's not a must, right? There is something called retained investments where you don't pay shareholders and you put it there, right? Or you pay workers. So I think that is very crucial. And we must not be blindsided, comrades, by their antics. Okay. But the question that I was asked is around the medical claims that are increasing. Indeed, this is definitely tied, we believe, to the poor working conditions that health workers face. I mentioned a passing comment, which is a very crucial comment, which is that currently within our healthcare sector, we are seeing a de-skilling and a de-professionalization of the healthcare system. That is very crucial for us to know. Figida will can talk more about this, but what we're seeing is that certain grades, so when you're thinking about the nursing fraternity, there are particular levels. Nurses that are at the top level would be those who can actually maintain and control a whole ward. We are seeing those nurses now being, and that takes a particular level of skill to have. It takes training to have. We are seeing nurses who are taking up, who are at lower skills, taking up higher skills without getting fairly rewarded or paid, right, based on that. And that is a cost containment strategy, okay? We are also seeing how the curriculum is being used as a way of watered down and deprofessionalized. That is a cost containment issue, okay? So that, of course, has an implication on the quality of care that we receive within these within the space. So this is something that we need to watch very, very closely. It is a ticking bomb, and yes, you are correct. Whoever posed that question, I don't know if it was a Power FM radio, but it is correct to say that there is a direct link, and that's what our report reveals. Thank you very much.
Thank you so much. Yes, that was a question from Robinson at Power FM. I would now just like to ask, there are questions being asked about where the report can be accessed. Has the report been put up onto Oxfam's website, or where can people access the report?
Absolutely. The report can be accessed at www.oxfam.org.za/care4carers. The 4, the number 4.
Asanda, I will ask you to please post that in the chat so that everybody can have access to it. Thank you so much for those answers from Basani and Ruth and Figile, and for all of the questions that we got around the report specifically. In order to flesh out some of the findings that we have from the report and some of the more technical things that you've heard, we'd now like to invite some healthcare workers, people who are actually working on the ground around these issues, to speak to some of the issues mentioned in the report. First off, I would like to ask Sibongile Shabalala, who's the chairperson of the Treatment Action Campaign, and Anastasia Madagane, who is from NUPSAW, to speak around the impact of the shortage on medical supplies, on the work of healthcare workers, but also on the quality of care that people are receiving. Sibongile, I'd like to start with you. Sibongile is the national chairperson of the Treatment Action Campaign and has long been a social justice activist on health and rights issues affecting women and the poor. Sibongile, please, will you speak to us?
Thank you, Sis Tembile, and thank you for having me. Good morning, everyone. I'm going to focus more on how the system has affected the patients. Let me start by saying, if the healthcare worker is not happy, obviously the patient won't access quality healthcare services. If the healthcare worker is not taken care of, it means the patient will not be taken care of. So I'm saying this because the COVID-19, as almost all of you have said, that it has exposed our healthcare system, and it's been clarifying all what we have been saying all over the years, to say we have a broken healthcare system and our healthcare system is in crisis. We have seen a lot of challenges in the healthcare system, despite our readiness, the readiness that the government has talked about. And now it shows that we are not ready. We don't have a quality healthcare system as enshrined in the Constitution. And people are not getting a quality healthcare system in facilities as they are supposed to. I'll just make one example that we are working on with Section 27 and ICAS in Eastern Cape. I think everybody have seen what is really happening now in the Eastern Cape. And we are seeing one of the hospitals, which is the Livingstone Hospital. That hospital is in crisis. It needs emergency assistance. And you can ask yourself to say, if the hospital is in crisis, there are no PPEs, they are understaffed, and clinical and non-clinical staff, they have so many challenges. They are having COVID-19 cases, infection cases every now and again. What does that mean to the patient? What does that mean to the healthcare worker? And mostly we know that people who are using healthcare services are women and children. We are not saying that men are not using it, but when you go to facilities, majority of people who are using or are accessing services are women and children. I will just reflect on the Stop Stockout report that we conducted recently. We found out that in facilities that we managed to talk to, 35% of face shields were not available. N95 masks, 22% of those were not available. Hand soap, 6%. Hand sanitizers, 4%. What does that mean to the healthcare worker? What does that mean to the patient? So we are seeing a rise on infection of COVID-19, not because maybe people are not only complying with the regulations of lockdown, but the healthcare system also contributes to the infection of COVID-19. We have seen so many facilities where they were closed because nurses or doctors were infected because of COVID-19. What does that mean? At the end of the day, when the facility is infected with COVID-19 or it has positive cases of COVID-19, what does that mean to patients? We have seen patients not accessing their treatment. And at the end of the day, the very same government, our government, say people are not going to access their services. Let me talk also about contraceptions. 33% of contraceptions medicines were not available. What does that mean to women? It means women were forced to have sex without contraceptives, and the safe abortion services were suspended during the lockdown. What does that mean also? It means we have a lot of unwanted pregnancy that are not planned, and when even women wanted to take precautions to have contraceptives, they were not given. So their right to reproductive rights was violated, and nobody says anything about that. We have seen the rise of shortage of ARVs in the country, and we know that South Africa, we have more than 8 million of people living with HIV. If they're not accessing their medication, what does that mean? And we just learned recently to say people who are living with HIV, TB, and other chronic illnesses are in higher chances of being affected and killed by COVID-19. So our system failed both patients and healthcare workers. And what does that mean? It means we have to come up as a country. We have to say it like we need to advocate. We need to be harsh to the government to say whatever we are saying, doesn't talk to us. They are budgeting now. We just learned that they have taken the past 3 months they have said from the conditional HIV conditional grant, and because they were suspending services so that they can be able to save. Now they're telling us that that money will be used to print pamphlets that talk to COVID-19. The question is, how many people are still using pamphlets and that media space? People, they need to hear from people to say what is really happening. We need to use social media, which cannot require 6 billion rands to do that. So why are they saving by killing other people? If people are not accessing treatment, while on the other hand, they want to save money to do that, that is not fair, and our government is not taking care of us. So from the side of the patients, we are not happy the way things are, and patients are suffering on the ground. And the minister on the national level is saying something different to what is really happening on the ground, which is very problematic. So I will stop at that.
Thank you.
I've taken so much time.
Thank you so much. You spoke for exactly 5 minutes, and thank you so much for really delving with so many different issues. And I think that the importance that you're talking about is the impact on people who are accessing healthcare, and this idea that you can deal with COVID-19 by taking resources from other areas. And so by taking resources from reproductive healthcare, by taking resources from the treatment of HIV, we actually are potentially creating a lot more problems. And I think this issue also around the resources and the stocks of hospitals, I think is a very important one. Zwelinzi Mavadi tweeted this morning that his sister has been rushed to Hewu Hospital in the Eastern Cape seemingly with COVID-19, but she still hasn't received her test results, even though she did her COVID test on the 1st of June at Freya Hospital. And now that she's been admitted to hospital, she has to bring her own blankets and her own pajamas. And so our healthcare, our hospitals themselves are really potential sites for the spread of COVID-19. I would now like to ask Osis Anastasia Madagane from NUPSAW to speak to us a bit more about these issues of stockouts. She's worked for the Department of Health for 21 years and has been involved in a whole number of areas around healthcare provision, particularly in Mpumalanga province.
Thank you very much. Good morning, everybody. I would like to appreciate the leadership of Oxfam South Africa for inviting me to participate in this campaign. Actually, I'd like to highlight the critical objective thing that as a community health worker, we are experiencing and we are seeing. They are as follows. As the community health workers in South Africa, we are experiencing, as we are working under the Department of Health, we are experiencing that we have a shortage of protection and safety. Like for instance, since we are experiencing this pandemic thing, it's not because of the pandemic. Actually, the Department of Health is been using us at the front line of everything, because now they will be behind the mask of the pandemic. Actually, they were delaying everything for us. They were denying our right as a community health workers. Since we are working as for COVID-19, we don't have PPEs. We only just receive masks once in a week. We only told to go and sew our own mask. We receive a sanitizer. And we are screening, we are testing patients. We are not even get tested. We are asking for the department to give us a mass testing so that as a community care workers, we will know our status in this current pandemic thing. The improvement in condition. We are working under the sun, under the weather, under the windy weather. We are screening the patient in front of the gate, whether it's hot, whether it's windy. We don't have any shelter where we can say this is our working place. We even go to door, and we are not even protected. We don't have any risk alignment. And when I'm talking about this, because there is the other time where the community health care workers was bitten by a dog. And then when he's bitten by the dog, it's not even covered to the Department of Health. So we need to, in this campaign, we need to go vocally so and radically so that we can get help and get protected. And our voice will be heard by the Department of Health. So in terms of medication in our facilities, we've been running shortages of all sorts of medication. In this lockdown, people were supposed to be indoors, but people were roaming around the street, going to the clinic, looking for their own medication, for the chronic medication, which they turn away because there will be no medication that will be given. They will just to be chased away and go back home and come back again. So there will be the people, the patient and the community were affected because they didn't receive anything, and they will be roaming around the street and because of the shortage. And the department will be hiding in this mask of the pandemic COVID-19, which is the delay of implementing things. In some of the hospitals, some of the community members, they are already dead because some they were denied to have operations. Some they will turn away, they say they will look after September, they will look after this pandemic, this COVID-19 when it's passed. Some they already lost their lives because they didn't have any money to go to the private sector so that they can perform the surgical operations and all those things. Thank you very much.
Thank you so much, Sis, for all of that detail that you've given us, and and also for raising the issue that community health workers have been an important part of the system for a long time. It's not just a new COVID-19 innovation. And so while you've got the National Health Department, talking so much about community health workers now, as if it's a new thing, and indeed, the World Health Organization speaks about how brilliant South Africa's response to COVID-19 COVID-19 is on the basis of the use of community health workers for screening and testing, and yet we are learning from you just how in danger those community health workers are, because there is no PPE available to them, they don't have access to testing, and even when they are then put into danger in the course of their work, like the example that you were giving with the person who got bitten by the dog, they don't have access to healthcare themselves to be able to help and to protect them. And so these are very major issues that we need to keep raising. So thank you so much. Next, I would like to call upon Sister Maredi and Sister Lebu, who are going to talk a little bit more about the conditions of the work conditions of healthcare workers, particularly in relation to job insecurity and chronic understaffing. I would like to turn to you now to speak to us about that. Yeah, it's Maredi, please, to speak to us. Maredi, please, to speak to us about chronic understaffing and in relation to your work.
Greeting everyone, and thank you to Oxfam SA for giving me this opportunity to be a part of this campaign. I'm going to talk about the effect of the chronic shortage of staff on my health and at the work. And I'm going to start at work. This chronic shortage of staff at the workplace has resulted in negligence, malpractice, omission, and conflict. When I'm talking about negligence, I'm talking that when a patient came to the health sector, she or he expects a quality health care that he has voted for, that he has been promised to by our very own government. And on arrival, that patient meets a nurse that has to take care of a lot of patients being alone or being understaffed. When I'm saying understaffed, I feel like it's underestimated, is a severe chronic staffage. It's when a patient, as a nurse, you have to dissect yourself into many pieces in order to cover the whole population that is there at that particular day. And somehow other patients will feel neglected. Remember that patient was promised a quality health care. Then when she arrived at the facility, she finds you are burnt out, you cannot please them all, you cannot satisfy them all. There will be others who will be feeling neglected. And yes, they are neglected. And when I'm talking about omission, is that as you give this care to these patients, if the staffing was appropriate, we are going to do things properly according to the procedure. As nurses, we are taught to do everything according to protocols and policies, but somehow we are going to omit something because there is a long queue waiting for you outside. You cannot be nursing this patient holistically, so meeting their psychological, their physical, and their emotional needs. As you already have a pressure, you are feeling the pressure, the time is going, you arrive at 7 o'clock, you have to knock off at 4 o'clock. Who should be left at the facility? You should attend to them all, hence others will be omitted. And at some stage, you as a nurse will have to choose between records and the patient, because if you didn't record, you didn't do it. You know, in nursing, what's not written is not done. And then while focusing on the records, the patient will be neglected. When focusing on the patient, the records will be neglected, and negligence of the records can lead you to hearings and all other disciplinary measures. So this chronic shortage of staff has placed nurses in a situation where a nurse has to play, actually a nurse has to play God. You have to choose who to live and who to die, because you're in a dilemma. Both of them, they require an emergency care, like now you are alone. You will end up at the end of the day, you will never, like if I cannot show you any nurse who will walk out of this facility, at the public facility saying, today I have done my work, I'm satisfied. Every day there is this one that you didn't treat well, there is this one that you didn't give a proper health care. And This thing is, like, for an example, and it's frustrating in the maternity unit because we don't know the situation. Like, gender-based violence is everywhere. In health is worse because we don't know the situations of these women. They came, they're having their first babies at the very later stages. They have been through miscarriages, through ectopic pregnancies, and then they have to face you, one midwife. You have to attend them, all of them. All of them, they're head and perineum, they are ready to push the baby out. Who are you going to attend first? Who are you going to attend first? Who deserves to deliver alone inflicted? Whose delivery is not special? Then if it's a man, even if you is a one patient, remember midwifery is a mother and a baby. You deliver a mother and the mother complicates, we call it postpartum bleeding. Let's say it's bleeding, you have to manage, and the baby is lacking oxygen. Who are you going to prioritize between the two? That's the dilemma we always find ourselves in. So, and it have resulted a serious hatred and conflict between the society and the nursing personnel. Because unfortunately, our people don't understand how the system works. Earlier the presenter said nurses were viewed as a system itself. Like, when you arrive at the facility, you expect the nurse is responsible. Like, they cannot, like, the community is not aware that we are just like them. We are just from our homes. We just get into the facility and utilize wherever we find there at whatever time. So it has resulted a lot of conflict at the workplace, and it has resulted in demoralization of staff because nurses don't feel appreciated. Even themselves, they cannot appreciate themselves because they will never say, I've done a good job today. Even if you can do a good job now at 9 a.m., 10 p.m., you'll be having someone who's not satisfied, and you know you didn't satisfy that person. So you will always feel demoralized and appreciated, like, what's wrong now? You see. And when coming to the health of a nurse, I highlighted the mental well-being, which is first of all, is a burnout. Nurses are burnout due to long working hours, this 12-hour shift on your feet, caring for people of different problems. And on the other one is this thing of the community and our society. There is this Asian status quo of that cultural that a woman should carry all the burden on herself. Hence they say, so that norm is being instilled in nurses because it's a female-dominating career. We were expected to be like to jacks of all trades, to be superhuman, not to have those feelings and to react. And on the other one is when we are having feminists, by the way. On the psychological one, that I can boldly say I'm affected as an individual. I am afraid to have kids. Who will look after? I'm having one girl now, is 5 years old. She will be having a second one. But the situation I'm finding myself in, I work far away from home. I work long hours. I don't have time for my child. Then if I want to have a second baby, who will look after, why will she get, I'm forever having this connected bond between mother and child. And there is on the physical well-being of a nurse, there is no healthy lifestyle. You work long hours, you are tired, you arrive, you eat quarter, you sleep. There is no time to sleep, there is no time to exercise, there is no time to meditate. And other nurses, like when you stay at nurses' home, you are obliged to work, even if you've knocked up. Because when you are staying in the clinic, when the patient arrives, they'll have to wake you up. You have to go and attend that patient. 9 o'clock, 10 o'clock, 11, 1 o'clock, 3 a.m., you wake up and attend that patient. 7 a.m., you're expected to be on duty. That's how it works.
Thank you, sis.
To not off late, because in the rural areas where I come from, there is no transport. The roads are in. When you are waiting for an ambulance, you will wait. You will wait, and you will knock up for very late. And gender-based violence has been experienced by nurses who are working standby. Like, we had that incident whereby the patient, nurses working on standby, they just work on a skeleton. It's not a full staff. It's for emergencies. Then you will feel patients are harassing nurses in such extent that you will ask yourself, will she do these issues at the police station?
Yeah.
No. Because I'm just a woman, and our cultural, a woman cannot speak. So nurses will be viewed as disrespectful, because I think nurses were the first women to enter the career level. So, okay, that's why
can I ask you to please wrap up, Sister Mahadi, so that we can ask Sister Lebohang to be able to speak as well about her experiences?
Oh, okay. Otherwise, I've touched all the spheres that I wanted to touch. Thank you.
Thank you so much, and thank you for just explaining so passionately and so in so much detail exactly how difficult the lives of nurses are. And you know, when we talk about you know, work, what it takes to be satisfied with your job, and you are describing how the conditions that you work in make it impossible for nurses to be able to do a job that they're proud of. So thank you so much for that. Sister Lebohang, can I hand over to you, please, to tell us a little bit more about job insecurity of nurses especially?
Okay, thank you very much for this opportunity. Thank you, Oxfam SA and the Young Nurses Indaba Trade Union and all the organizations who are participating in this campaign. I'm Lebune Bukula, a professional nurse. Job insecurities in private sector as an agency nurse is very hard. We don't have any benefits. I don't have medical aid. I'm not covered by those normally sick leave. If I can get sick, it means that no work, no pay for me. No maternity leave. It means that during those months, I'll be having no salary, no money, no nothing. And even if I can die, my family will not get anything because I'm not covered anyway. Because the way we get paid on how they book you. If they can book me maybe 2 days per week, at the end of the month, it means that I'll be getting salary for 8 days. So it's very, very difficult. Sometimes I'll go to work telling myself that I'll be working 12-hour shift, only to find out that I'll be cancelled after working only 4 hours. Or sometimes I can go there and be taken away and told, Lebu, we forgot to call you, you are cancelled. And they don't even give me maybe money for transport to say, at least Lebu, take money for transport as we've cancelled you. Sorry for this. And we are very, it's very, very bad. Even during this difficult time during COVID-19, for me as an agency nurse, it means that if I can get tested positive, it means that I will not be having any money because I will not be working, I'll be quarantined at home. So it is really, really bad. Even it affects my wage and my family life. I can't plan anything. I can't have a bond house. I can't have a car. I can't even pay school fees for my children because remember, I don't have a salary that I know that maybe month end I'll be getting this much. I get paid according how they book me. And we also fall victims of malpractice because as an agency nurse, if anything goes wrong there, even a doctor does something wrong, it will be blamed on you, agency nurse, because you are not protected anyway. You are just an agency nurse. Anything that can go wrong anywhere, they will blame you, an agency nurse. We even fall victim of abuse at a workplace because even if there are those difficult patients, they will be allocated to an agency nurse and you will get more numbers of patients regardless of you are alone, and they don't even help you. They know that you need that money, so if you can refuse, it's easy for them to just say, we are no longer going to book Lebu as she refused to take those difficult patients, so we'll cancel her, we'll fire her, and they don't care because there is somebody that they will get immediately. So they just allocate us during this time of COVID to those COVID COVID-19 was without any proper infection control measures. Just imagine be given just a surgical mask, this mask for 5 days. Like working, maybe being allocated there for 5 days, being booked for 5 days, using one surgical mask, you'll get another surgical mask there after 5 days. It's not proper infection control measures. It's not. It's very, very painful because labor brokering is unconstitutional, but it's still happening. It's still happening. And many people, maybe they think private sector is best. Even now during COVID-19, private sector is safe. Maybe if I have a medical aid, even if I can get infected and go to private sector, I'll be safe than the person who will go to public sector. It's not true, because there you will get infection like any other public hospitals or clinic, because then agency nurse who's working there, for example, maybe she's working at Life Hospitals. She also do moonlight again at Netcare. She can work today at Life Hospital, tomorrow she can go to Netcare, the other day she can go to clinics, the other day she can go to Mediclinic. It means that the infection, she's carrying the infection and she's spreading the infection.
Thank you so much, Sister Lebu. Yo. What you are describing is absolutely horrific, that you can have such a system of exploitative labor for the people that we expect to care for 6 people, and that you can have agency nurses. And I think, thank you so much for pointing out that this idea that people think that the private system is better, it's not. Because the exploitation of the nurses in the private system means that it endangers everybody that is using that system too. And it's just ridiculous also that if you were to get sick yourself with COVID-19, that you wouldn't have any medical assistance to help you. And the thing is, people use these systems and they don't know what's happening behind the scenes, and they end up blaming the nurses when they don't get proper care. Ganti, this is the conditions that the nurses are working under. So thank you so much for sharing your story so passionately with us. I would now like to call on to Umamo Catherine, who is a community health worker working with YNITU, who is going to speak to us about the impact of the gender-blind workplaces on nurses, particularly around the issues of public transport and the balancing of home and work responsibilities. Ma'am Catherine, I'd like to hand over to you.
Thank you, Madam Chair. Thank you very much for giving this opportunity. I'd like to thank the Oxfam family for giving us this chance to do this. My name is Catherine Mudisa. I think at Bande. I'm speaking about the safety of the care workers. I'm working as a community care worker. I'm working under a stressful situation whereby where I'm working, it is in a place, it's like a rural place, because you see Orange Farm got a lot of gangsters, and we are not safe. We wake up early in the morning. By 5 o'clock, I should be away to go to work, and I'm earning a stipend of 3,500, and which is very little for me. As a mother of children, I've got 4 children, and again, I've got a sick mom who is diabetic. I have to look after her. I have to take her to hospital sometimes to fetch medication. So I don't have much money, because from that 3.5 I'm earning, I took 1,000 for transport for me to go to work, because where I'm working is far from where I'm staying. So that 1,000, it doesn't allocate me for the whole month. Maybe on the 12th, because I'm using two transport to go to work. By the 12th, I should go with fit, and you see my age, I'm old now. I must go to work. At 8 o'clock, I should be at work, and then I'm working 8 hours. By 4 o'clock, and then when I arrive home, I'm tired because I'm working with patients. I'm doing the house. What do you call this? We visit we do the house visit. We visit patients to give them treatment. And by visiting the patients to give them treatment, those who are old or those who are very sick, we give them treatment at their places. And it's not safe again there because there's a lot of gangsters at my place. Is the Masutu gangsters, and then these boys from the initiations, what you call them, those boys. Sometimes, yes, and this one who are using the Nyaupe, even the medication that we are carrying is a target also, because they take our bags, and we don't have too much material. Government doesn't want to give us the material. Because sometimes in my bag, I'll be having that medication and my cell phone only. No money inside, then they'll take it, you see, and they stop us. Sometimes when we knock in their houses, we are not safe too, because they want to say, come inside, and only one that is only boys inside there. It's not safe for us. Even some they want to say, come inside, they know that there is dogs outside there. We are not safe. Then if we come across maybe with an incident whereby we get injured in the field, when we go to police station, the police will make jokes out of you. They will laugh at you, maybe we have been raped, all those stuff. They will make jokes out of that incident of yours. They will ask you, what were you doing there? Because that place is dangerous. And it's where I'm working. I have to go there, whether I like it or not. I don't have choice. And when I have to eat, you know, I don't have enough time because I have to work with patients. My time is very little. As I said, even the money that I'm earning, I'm paying even I don't have the money to buy maybe for furniture or for something. The money that I'm earning, as I said, I took out 1,000 for transport. This other 2.5, it don't even cover me for whatever. I remember one time I was in a problem whereby my house was get burned. I burned the house by mistake. So I had to buy some other things. I went to the loan sharks to borrow the money. From one loan shark to another, to pay the other one because it promised to kill me or whatever. They took my bank card, even my ID. You see, there's nothing that I'm going to end because I don't have chance. I'm a human being. I don't have to open the installments to buy whatever. I'll just see that even if I want to buy nice things for my kids, I won't buy. I won't buy because I've got nothing with me. I'll just buy things those we can stay without. Maybe meat, we just eat meat maybe after a while because government doesn't give us even the product. It just give us this 3.5. Doesn't want to employ us. Just, you know, we are just left like that. And there's nothing that we can do. We have to work because there's no job in South Africa. Companies, they keep on retrenching people each day. They retrench, and as I'm working, I'm a breadwinner in my house. I'm the only person who's working. All those people, 4 people plus my mother, they are all off my shoulders. So I don't know what am I going to do. And the government doesn't want to absorb us. It just signed a contract. Each and every year, we renew the contract. We keep on asking him for maybe he can just add with other money to maybe to earn 4.5 at least. That 4.5 is still little, but at least it was going to make a difference. But it doesn't want to keep on promising us, and he got empty promises for us. He don't care about us because of, you know, they took us as people who are not educated. Yes, we are not educated, but not all of us. We do got matrix, we do got whatever. He doesn't want to take us to school, as our comrades have said a lot about us. I'd like to thank you very much.
Thank you. Thank you so much, Ma'am Catherine, for sharing your story. It's terrible to hear about the conditions that community health workers have to work under. And, you know, we'll say that community health workers, yes, may not have a high level of formal education, but it's incredibly highly skilled work. because it's the kind of work that is necessary to keep other people alive. It's high skilled work, and it needs to be recognized as that, and to be given some protection and permanence in the system as well. I'm now going to call Sigile to speak to us about the NHI and what that can do for worker and patient rights.
Hi, everybody. I'm back again with my COVID voice. Yes. Let me try to get my video on. Yes. You know, when we looked at the universal health coverage,